At least we got a picture. They just haven't turned it on yet.
Nelson County, your mic is on.
Thank you.
You're welcome.
Good morning, everyone. Glad you could all join us for today's Public Health Nursing Update ITV. I'm Rosie McClavick, Director of Nursing for the Department for Public Health. We have an exciting agenda today. And first, to lead us off, we're really honored to have our guest speaker. This is Dr. Melissa Curry. Dr. Curry is Associate Professor and Director of the Division of Forensic Medicine at the Department of Pediatrics at the University of Louisville School of Medicine. She's participated on numerous committees. She's a strong children's advocate. She's a medical consultant for the Department for Community-Based Services, DCBS, and she's developed this presentation in collaboration with the Just for Kids organization, of course, state government, COSAIR's charities, and Prevent Child Abuse of Kentucky. So please give a warm welcome to Dr. Curry.
Thank you very much. Good morning. It's good to have all of you here. We can go ahead and start the PowerPoint slides if you'd like. I do want to just give a couple disclaimers and sort of set some ground rules, for lack of a better term, for the presentation today. First of all, there's a lot of material to get through, and it can be kind of hard to get through all of it in an hour and a half. We'll do the best we can, but it's actually much more important to me that we have some interaction and ask questions and have some discussion. If there are some slides at the end that we don't get to, that's okay. You can read that stuff in your handout. It's kind of front-weighted so that the most important stuff is at the very beginning. So please feel free to ask questions. I don't mind being interrupted at all. The second thing that I've actually learned since giving this presentation to hundreds of people now is that it's probably important for us all to realize that in a group this size with this many folks participating, there's a very good chance that there are people listening who have been personally affected by pediatric abusive head trauma. And because of that, just be mindful of the questions that you ask and the way that you ask them, that there may be folks who actually are either family members or friends of children who have been victims of this. We have folks who have adopted these children. We have folks who are the non-offending caregiver of these children. So I just wanted to put that disclaimer out there so that we realize that this is very common and it's not necessarily something that just happens to other people. It happens to everybody. I'm going to go ahead and get started. Of course, we always have to give our disclaimer at the beginning of any continuing medical education that I have no financial gain or ties to any of the information that I'm providing today. The services that we provide at University of Louisville Pediatric Forensic Medicine are free. They are provided to families and the people who refer to us either through contract with the state or pro bono, free of charge. So all of our support comes from state DCBS, local police, and philanthropy from charity, including COSAIR charities, as was mentioned earlier. So we don't charge for our services, so I just wanted to offer that as a disclaimer.
Dr. Curry, before you get started, I meant to announce that the handouts don't have the pictures that you're going to show. So if you would, I just want everyone to know that because of the sensitivity of the photos are not in the handouts that went out in the PowerPoint that we sent out electronically.
So just to repeat that reminder, if anybody didn't hear it, there are lots and lots of photographs of injuries in this presentation that are not going to be in your handout, and that was done intentionally because we don't like to reproduce and distribute those photos of those children. So there will be a lot of additional stuff visually on your screen that you're not going to have in your handout, but all of the printed stuff is in there, so you shouldn't have to take many notes. Okay, so to start out, the reason that we're all receiving this training, other than the fact that we obviously care about kids and we want to know everything we can to help advocate for them, is that here in the state of Kentucky last spring there was a new bill signed into law. It was House Bill 285. It's known as the Shaken Baby Bill, and it essentially mandates training on pediatric abusive head trauma for a wide variety of professionals. That includes nurses. And nurses are probably the largest audience that have been trained so far. In addition to nurses and other professionals, it also mandates training for foster parents for medically fragile children and any foster parents that have children. I think it's 5 or younger. It might be 3 or younger in their home. So that was sort of the seed that got this presentation growing. And we have developed these modules for individual professionals. So the one you're hearing today is specifically for nurses, and I'm going to try to give some examples that are particularly pertinent to public health nurses in the role that you all play in helping our families in this state and helping protect the children. I'm not going to read the objective slide to you. It's in your handout, but basically I'm going to cover just about everything there is along the entire spectrum of pediatric abusive head trauma. We're going to talk about the injuries themselves, how we look for them from a medical standpoint, how these children tend to present for medical care, what kind of signs and symptoms they have. We're going to talk about their outcomes, and then cover some statistics and epidemiology about what types of families is this most likely to happen in. And then we're going to end the presentation talking about prevention, since that's really the most important part of all. So to start with, just to make sure we all understand the terms that we're using. You've heard me already use the term pediatric abusive head trauma. All of you are probably familiar with the term shaken baby syndrome, and that is really the term that is most well recognized out in the lay public. But from a medical standpoint, for medical providers, we're encouraged to use the term either pediatric abusive head trauma or pediatric abusive head injury, and that has been the preferred term since about 2009, and the American Academy of Pediatrics actually released an official statement requesting that we use that term. Without going into too much detail about what has led to this evolution of terminology, it basically is a consequence of the courtroom. The term shaken baby syndrome is referring to one particular mechanism that can cause fatal or disabling brain injury in children, and that's shaking. And we know that shaking a child violently can cause serious injury and death. But sadly, what we've learned in working with these families and these children is that the children oftentimes aren't just shaken. Oftentimes they're shaken and then either slammed into a surface or thrown into a hard surface, so they may have impact to their head as well. And so the term shaken baby syndrome does not necessarily encompass all of the different mechanisms that can be involved in this kind of abuse. And so that is why we've chosen a term that will be more all-encompassing and not restrict us to just one particular mechanism. That being said, if we're educating the lay public and non-medical audiences, we're encouraged to just continue to use the term shaken baby syndrome because that's what people recognize. And I think if we start trying to change the terminology at this point, it's just going to create confusion. So I'm not going to do a lot of statistics, but I'm going to cover enough so that you can get a sense of how big of an issue this really is, both nationwide and here in the state of Kentucky. First of all, abusive head trauma is the most dangerous form of physical abuse. Okay, it has the highest mortality rate and the highest morbidity or disability rate of all the kinds of physical abuse that we see occur in little kids. And as you can imagine, it tends to occur mostly in children under a year of age, but not necessarily. It can go up to 4 years of age. There's even a case report of a child 8 years of age that had the classic findings associated with shaking. It is the most common cause of death from brain injury in children less than 1 year of age. And I'm going to just sort of give you some perspective on some of these numbers. In 2007, Kentucky was the first in the nation for child abuse fatality rate. So definitely not something to be proud of. We like to be known for our horses and our basketball, but we certainly don't want to be known for child abuse. But unfortunately, it is a significant issue here in the state. Now, since that report was released, that was the 2009 report based on 2007 data. The 2010 report had us falling to 17th. So there does seem to be some improvement, but obviously 17th isn't really a number to be proud of either. The 2011 report should be out in the next month or two. I also, though, want to offer you just a little bit of background as to how these numbers are gathered, because I think it's important to understand that there are actually some things that we do well here in the state of Kentucky that may have led to us being first on the list. And one of them is our medical examiner system. Okay? In the state of Kentucky, when children die as a result of abuse or inflicted injury, our medical examiners here are very good and very likely to recognize, and therefore those children get counted. Okay? I'm going to just pause here for just a second because there's some noise interference.
Okay. This site, we just heard an announcement over a PA system. So your site just had an announcement. Could you double check your mic and make sure it's muted, please?
So here in Kentucky, our medical examiner system is very strong. So when children die as a result of abuse, they're more likely to be counted. And that in and of itself can artificially elevate our numbers a little bit, because there are other states where sadly that's not the case. And so while their numbers may be lower, it doesn't necessarily mean that they don't have as significant an issue of child abuse as we do. All of that being said, there's no question that this is a significant problem here in the state of Kentucky. We average 30 to 40 deaths each year due to child maltreatment. And then we have another 30 to 60 children who have what we call near fatalities, and that's children who are in either serious or critical condition as a result of their injuries. More children die under circumstances of maltreatment between the ages of birth and a year of age than all of the accidental causes of injury in Kentucky put together. So think about this a minute. Think of all the prevention programs that you're aware of, that you see on the billboards, on the sides of buses, and handouts at the doctor's office about poison prevention, fire prevention, and the smoke detector laws. All of the things that we've done with car seats, as far as legislation to mandate car seats and booster seats, drowning-related deaths, and all of the regulations about fencing around pools, and all of those kinds of things. When you look at all of those put together, you can see here that in our littlest kids, birth to a year of age, homicide takes up the biggest chunk of that pie. So you put all of those accidental causes of death together, and we still lose more children to homicide in this state than all of the rest of those combined. And I'm not sure at all that that's a message that's well disseminated. I don't think that we, as a population, really understand that that's the degree, that that's the severity of the problem in our state. And this is specific to Kentucky. This next pie chart is very similar. It's just including children up to 4 years of age. So once you start getting the toddlers who can get into things and run out into the street, the maltreatment or homicide-related deaths are still as big a piece of the pie as anything else. Motor vehicle ends up taking up a little bit more, and then again, fire and poisoning is a smaller chunk. Now, this is a really important concept, and it's one that is going to be woven throughout the rest of the presentation this morning, and that is that it is very, very unusual for a child to be seriously injured or killed the very first time that they're abused. So what we know from studying years and years of these cases is that, contrary to popular belief, this does not tend to be it can be, but it doesn't tend to be a loving parent with poor coping skills who just loses it one day and shakes their baby. What we've learned after looking very carefully at these cases is that the vast majority of these children have evidence of prior injury. And even studies of perpetrators telling us about what they have done tell us that oftentimes these children are shaken many, many times before they ever are hurt severely enough to be brought for medical care. In addition to the shaking injury, we have injury to the rest of the body as well. So what this tells us is, because it's an escalation of violence over time, it means that there are oftentimes early warning signs when the violence is just getting started, that if we learn to recognize, we can actually do something about this. So while it's disheartening to hear that these children are in homes where this is going on over and over again, it's actually encouraging for those of us who might be interacting with these families and can pick up on the early signs. If it just came out of the blue like a bolt of lightning, there would be practically nothing we could do about it. But it turns out that that's not the case. nurses in particular, especially public health nurses, because so many of you are out in the homes and in the communities and seeing the family unit together, are in such a unique position to recognize these early signs and intervene on behalf of these children. So I'm not going to go through this long list, but when I give this presentation to other nurses, it's just really important, and probably all of you are aware, nurses are everywhere. You know, they touch really every aspect of society. We have them outpatient, we have them inpatient, we have them in the urgent cares, they're in our schools, they're in our health departments, labor and delivery, the list goes on and on. So there are lots and lots of different roles that nurses play where they're in a position to see and hear things that other people may not necessarily see or hear. Now, let's talk about the injuries themselves, okay? What exactly is abusive head trauma or shaken baby syndrome? Well, it is a global brain injury. It's injury to the brain tissue itself that's caused by the brain being whipped around violently inside the skull, okay? Now, just a little aside here, I'm going to be using words and mechanisms that are going to be a little hard to hear and to swallow. I doubt they're new to any of you, but it's not the lightest material to start your day out with. So just kind of an extra warning that I'm not going to sugarcoat any of this stuff. So the words that I use are used because I think it's important that we understand the degree of violence involved here, okay? The mechanism of this kind of injury can involve shaking, impact, or both, and I alluded to that already because not all of the children are just shaken, they're often thrown or slammed into a surface. The injuries that we see when we look with our medical tests, especially a head CT, the most common injuries that we find are subdural hematomas, and I'm going to show you some diagrams to explain what those are, where they come from, and what they look like. We can also see retinal hemorrhage. If there's impact involved, we may see scalp bruising or scalp swelling. We may even see a skull fracture, but it's the injury to the brain tissue itself that is causing the problems for these kids. That's what causes the disability and the death. The most common trigger, as you can imagine, is crying. And again, it is not typically a one-time event. So here's a diagram of a baby's brain, and I'm going to point with the mouse here. You have the brain tissue here. This gray structure right here is the dura mater. That's that tough covering that goes over the outside of the brain that's inside the skull, and for the purposes of illustration, that's been drawn as if it was reflected back, okay? This big structure right here is called the superior sagittal sinus, and it is a giant vein that is actually fixed to the inside of the skull, okay? So as the skull is whipping back and forth during a shaking event, this structure here is fixed to the skull, but the brain is going to be moving at a different rate, okay? So it's going to be going in a different direction at a different time than the skull. And there are these little veins here. They're called bridging veins, and they come up out of the surface of the brain, and they're draining blood into that superior sagittal sinus. And what happens is during a shaking event, when the brain is whipping back and forth, those bridging veins get torn, and they bleed into what we call the subdural space. It's on the outside of the brain, but it's right under the dura, so subdural, okay? That bleeding shows up on a head CT if we do it quickly right after the injury has occurred. So that is why a CT scan of the head is such a crucial component of the screening for child physical abuse, abusive head trauma in particular. Now this is just a different way of looking at the same thing for those of you who think a little bit differently. I know this one does not project as well, the next one's a little darker. But again, down here at the bottom you have the brain tissue. This is just a cross section. You have the bridging vein coming up out of the brain and draining into the superior sagittal sinus. As the brain is being shaken back and forth, that bridging vein tears and it bleeds into the subdural space. And that, again, can be seen on a CT scan of the head. Now, one of the things that I think is helpful to understand is why it is that babies are so vulnerable to this kind of injury. I mean, aside from the fact that they're young and dependent upon us, there are actually anatomical differences in the way their brains and skulls are formed that make them different from older children and adults. The first is, if you remember back to your anatomy class and you have an infant skull, pretend that you take the top off the skull and you look down inside underneath where the brain sits. And you probably remember there are lots of little nooks and crannies in there, and they all have names, none of which I remember. But the nerves come out of the brain to innervate the face and the muscles of the face and the eyes and all of that kind of stuff. Well, all of those little nooks and crannies are not as well developed in a young baby, especially a young infant, 2 to 4 months of age. It's much smoother. So just the bony encasement of the brain itself is not as well developed and not as prepared to hold the brain in place. Another thing that is different about babies is there is actually more space between the outside of the brain and the inside of the skull. So there's more room for the brain to gain acceleration and momentum during a shaking event. Okay, that allows it then room to accelerate and then slam in the front and the back and the sides and everywhere into the inside of the skull during this event. If you think about babies, of course, their heads are much larger in comparison to their body compared to when we get older. So during a shaking event, I mean, they have really no chance at all of being able to resist those forces because of the overall mass of their head. And then add that to weak neck muscles. Many of the babies that are victims of this haven't even or have just barely learned to start holding their heads up themselves. Another thing is that there is not as much myelin in a young baby. Myelin, as you remember, is that fatty protein coating that goes on our nerves in our brain and throughout our body. It helps propagate the signals, but it also serves as a protection for those nerve cells. And a baby's brain isn't myelinated completely yet, so there just isn't that coating on the brain cells to help protect them. And then the last thing is the water content. A baby's brain has 25% more water in it than an adult brain does. So if you think of underset Jell-O, or what happens when you add too much water to the Jell-O mix, it just sort of has a tendency to fall apart and never fully set up. That is the normal consistency of an infant's brain. Now, what doesn't cause abusive head injuries? I've talked about violent shaking, and I've talked about impact. And I think the popular media these days, in addition to the things that happen in the courtroom, really can create some confusion about what degree of injury it really takes, or what degree of violence, excuse me, it really takes to result in this kind of injury. Short falls, like rolls off couches and changing tables and things like that, do not result in this kind of injury. Now, they can, on very rare occasions, result in a life-threatening brain injury, and that almost always is due to something called an epidural hematoma. An epidural hematoma is what happens when a baby or an adult falls and gets a little skull fracture, and that skull fracture actually causes a tear in an artery. And that artery slowly accumulates blood, but it's under a lot of pressure. So these are the stories that you hear about where children or adults have what seems like a benign fall, not that big a deal, and then 4 hours later they're unresponsive and in an ICU somewhere. So there's no question that in rare instances, short falls can lead to life-threatening and even fatal head injury, but it looks absolutely nothing like shaken baby syndrome. It's a completely different mechanism, a completely different kind of injury. Okay? Epidural hematoma causes death by putting pressure on the brain, not by scrambling it. Okay? And that looks and behaves very differently. Bouncing a child on your knee, playing roughly with a baby, an older sibling who is handling a baby more roughly than you would like, none of that even approaches the amount of violence that's required to cause this kind of injuries. There are, theories, they're not really even theories, they're just defense excuses about immunizations and vitamin deficiencies and other things like that that can supposedly lead to these injuries. There's absolutely no medical evidence whatsoever that would indicate that that's true. And then oftentimes toddlers and pets are blamed for these injuries. And just to give you a visual to help you understand why a 2-year-old cannot possibly shake a baby hard enough to cause these injuries, Imagine what a 2-year-old can do with a full gallon of milk. All right? They can barely lift it, usually. Can they shake it? No. I mean, some mornings I can barely shake a gallon of milk, you know? It requires a lot of strength, and I think we have a tendency to attribute more strength to toddlers than they really have. They certainly are able to chuck a toy at the baby's head or throw a sippy cup at the baby's head. That is not going to cause this kind of injury. Birth trauma is actually a special case because, surprising to some, being born, especially through a vaginal delivery, actually is pretty traumatic for both baby and mom at times, and it can lead to subdural hemorrhages. Now, these subdural hemorrhages tend to be in a different location than what we see with abusive head trauma. They tend not to be symptomatic, okay? They come from the skull being distorted and kind of remodeled on the way out, but there's no brain injury associated with it, okay? But when we do MRIs of newborn babies, and we do MRIs because that doesn't have radiation, and so that's ethically allowable, we find that up to 25% of normal newborns whose brains are functioning just fine will have a small amount of subdural hemorrhage. But again, it's in a different area, and that all goes away within a month. So if we have a 2-month-old, 3-month-old, 4-month-old or older, we know that that's not birth-related because anything birth-related is resolved within a month. The same goes for retinal hemorrhages. Actually, the normal birth process can also lead to pretty significant retinal hemorrhages in many babies. Again, those tend to be resolved by a month or month and a half at the very longest. There's been one single retinal hemorrhage in the medical literature that was seen 6 weeks out. The vast majority of the rest of them were gone within 4 weeks. So again, if we have a baby with retinal hemorrhages or bleeding in the back of the eye, and they're older than a month and a half, 2 months, we can feel very confident that that has nothing to do with the birth process. Are there any questions from anybody about what kind of violence is required to cause this injury and what isn't? Have you heard any other theories that you want to ask about? I'm looking on the screen to see if anybody's reaching for their mic. Okay. So the American Academy of Pediatrics released what we call the technical report back in 2001, and this statement still stands from this report. And that is that the act of shaking leading to shaken baby syndrome is so violent that individuals observing it would recognize it as dangerous and likely to kill the child. Okay? These are strong words, and they're strong words for a reason. The American Academy of Pediatrics, as many of you probably know, does not just sort of write statements real quick and release them. I mean, it goes through literally hundreds of people who have a chance to say, no, we don't need to be saying things like this, or we need to word it a little bit differently. So there were, tons of experts who analyzed the medical literature to make sure that before the AAP released a statement like that, that there was good, solid medical evidence behind it. Now, I've mentioned impact already, and many of these children do have impact to their heads. One thing that's really important to understand, though, is just because there's been impact doesn't necessarily mean we're going to be able to see that from the outside. So there are children who will have, for example, a skull fracture, who on the outside of their skull you don't see any swelling, you don't see any bruising, okay? Oftentimes tenderness is impossible to assess because the children are brain injured and can't respond to pain the way a normal baby would. One of the things that we've learned is when some babies ultimately die, unfortunately, and go on to have an autopsy, when the scalp is reflected back, oftentimes we can see areas of impact on the scalp that we had no idea were there. So if a baby is alive and in the hospital, there is no way to rule out whether impact occurred to that child or not. The absence of scalp signs, the absence of skull fracture does not mean that the child did not have impact of some sort to the head. And this ends up really getting confusing in court, and the defense tends to use this to sort of create confusion. And the truth is, what difference does it make? Really? I mean, did you just shake the baby hard enough to kill or disable the baby, or did you shake them and throw them into something? Do we really care? Does it really matter? And so that's part of the reason the terminology has been changed, is because we need to encompass all of the different violent things that can happen to a baby's head. So the absence of evidence of impact does not mean that impact didn't occur. Now, I've mentioned the potential scalp findings, skull fractures, the subdural and the brain injury inside the skull, retinal hemorrhages. All of those are injuries within the baby's head that we may or may not see with this kind of injury. There are other injuries as well in other parts of the body that we may see when we start evaluating these children from a medical standpoint. They can have metaphyseal fractures, which I'm going to explain here in a minute. Those are breaks in the bone. They're in the long bones near where the joint is, so they're right next to the growth plate. You can see rib fractures. You can see fractures of pretty much any other bone in the body. We can see bruising of the skin. Sometimes it is on the torso, like the chest and the back, but actually that's pretty unusual. There's sort of this idea out there that we should be seeing bruising marks or finger marks from children who have had this kind of injury, and that's not necessarily true at all. But we can see bruising in other areas of the body as well. And then these kids can have internal abdominal injury also, and we have learned with time that we need to screen for that when any young children come into the emergency department with potential physical abuse. Again, one of the things to understand is that contrary to popular belief, most of these children have been injured before, and their injuries are not necessarily limited just to shaking and slamming. Oftentimes other mean, violent things have been done to these kids as well. And so we have to recognize that and make sure that we're looking for all injuries in any area of the body when we're assessing these kids. All of that being said, we may not find any additional injuries. We can just have subdural and evidence of brain injury. That in and of itself, with the appropriate history and the rest of the medical evaluation, may be enough to make the diagnosis. Metaphyseal fractures are breaks that occur in a baby's bone near the end of the bone, okay? When you're talking about the different parts of the bone, the long part or the shaft of the bone is called the diaphysis. The growth plate at the end of the bone, which looks like this little ice cream scoop on an ice cream cone on the x-ray, that's called the epiphysis. And the border between the two is called the metaphysis, okay? On this diagram, you can see that where the break occurs, it's a shearing injury across the bone, and it happens just next to where the calcium has last been laid down. So that on the x-ray, what you see, instead of a nice, smooth-edged, the metaphysis, like this should have been, you get this rim of bone that's separated. And it kind of looks like a bucket handle, or at least it did to somebody at some point, and that's how it got termed the bucket handle fracture. We also hear it referred to as the corner fracture, okay? The mechanism for this, when I say shearing injury, this is a hard thing to picture, but it's the only way I know to sort of demonstrate this visually. But if you picture a small baby lying in front of you and grabbing the baby very quickly by the shin and snatching it to the side so that you're literally like tearing the shin bone away from its connections to the knee. All right, it's perpendicular forces to the length of that limb. That's the kind of force that causes these injuries. And that can be from babies being snatched up violently by arms or legs. It can also occur, we think, during the actual course of shaking, where the limbs are flailing around violently, that in and of itself may be enough force to actually cause these kinds of injuries. Now, one thing just to explain for any of you that are wondering, when you look at a baby's bone on x-ray, rather than seeing the ends of the bones touching each other at the joint, what you tend to see are just the growth plate. So it looks like a scoop of ice cream on an ice cream cone, okay? That's because the baby's bones aren't finished growing, and a lot of the bone is still cartilage. And so it's only cartilage here and consequently doesn't show up on the x-ray. But in this x-ray, where my pointer is going around is the actual edge of the bone. Okay? Does that make sense to everybody? That one took me a while when I was in pediatrics. I couldn't figure out why kids always had these little extra bones at the ends of their bones, and I didn't understand that it was all one piece and that that was cartilage connecting it. Sometimes they forget to teach us the obvious things, so we have to figure them out on our own. All right, rib fractures. Now these are the most commonly associated fractures with abusive head injury, and they're the most common fractures in child abuse in general. This diagram will help demonstrate what happens, and essentially it's important to understand that the mechanism for rib fractures is a violent squeezing of the chest. So you can imagine how often during a shaking event the chest is being squeezed violently too. The two kind of go hand in hand. So the dotted line here is the natural position of the infant's chest, okay? But during a squeezing event, when the forces are pressing down and compressing that chest, a very interesting thing happens back here in the back, in the posterior area. The posterior rib actually bends against the transverse process of the spine back here, and it cracks on the inside here. And those are posterior rib fractures, and that's what that mechanism is. That is why posterior rib fractures are so specific for abuse, because you cannot have a blow to your back. You know, a baby can't be accidentally stepped on or hit or bumped into and get a crack on the inside of the rib, okay? Now, when the chest is being squeezed like this, you can also get cracks laterally. Those are called lateral rib fractures, and you can even sometimes see them in the front anterior. Those also are very worrisome, but they're not as specific because a direct blow can cause those as well. Now, obviously, there's really not many there are not many plausible scenarios for a 4 or 6 month old to have a direct blow to their chest accidentally, but it does occasionally happen. If that comes as part of the history, then that may actually be plausible. It just depends on the details of what they're saying happened to the baby. Overall, posterior rib fractures are highly specific for abuse. Again, just to give you some perspective on the amount of violence involved here, when we look at babies who had CPR done, both in the hospital and outside of the hospital by people who were not trained to do it, we still don't see rib fractures. So the amount of force that it takes to do CPR, where you're intentionally trying to get the heart, you know, to move blood through it, even that doesn't cause these fractures. So it's an amount of force that even exceeds that. And this is what rib fractures look like on x-ray. If you look to your left or the baby's right side here, this is the normal side. You see the ribs kind of wrapping around. They're all nice and even with sharp edges. You don't see really any unusual bulges the way you do right here on this side. As you follow these ribs around, it's like beads on a string. You can see these little bulges there. And what those bulges are is callus. And callus is new bone formation that is put down before the bone is completely healed and remodeled. So it's like a bone scar, so to speak. Now, when we see these on x-ray, and I've got them highlighted in with the circles down here to help you look at the right spots, when we see these aren't new. So if we had a baby that came in the ER having seizures and had evidence of brain injury, and this is what we saw in the chest x-ray, those didn't happen today, okay? It takes at least 2 weeks, roughly, to get this degree of callus on ribs after they're broken. When they're newly broken, particularly in the posterior area, sometimes we can't see that at all, at least on plain films. Even later, you know, if we get a follow-up skeletal survey in 2 weeks and we go back and we look at the original skeletal survey, even knowing where the rib fractures are, we still sometimes can't see them. So that is why a follow-up skeletal survey is so crucial to the workup for physical abuse. Now, this is a piece that you guys can really help with, because many times when these children are identified as abused, they're placed in foster care. Sometimes they're initially placed in medically fragile foster care, but then they improve to the point that they move to yet another foster home. And so they really don't get a medical home established the way that they should. I'm going to talk more about that later. But oftentimes they're still getting their shots at the health department, or they have a public health nurse that is sort of one consistent thread in this baby's life, no matter what home they're being moved to. Many hospitals and facilities here in the state do not know that they're supposed to be doing these follow-up skeletal surveys. So if you have a baby that's been diagnosed as physically abused and they're discharged from the hospital before that 2 weeks is up, you may very well be in the position to be the one person that knows that this follow-up needs to be done. And this is a huge piece of the evaluation that we often fail to do. If a child goes to Kosare Children's Hospital, it's going to happen. It's going to be taken care of and ordered and arranged. But really anywhere else in the state, that has not become standard of care. So you're going to leave here today knowing more than most of the physicians in the state about the evaluation of child physical abuse, which is unfortunate, but it needs to be empowering to all of you. Because once you leave here and leave this training, you need to share this information with everybody you know, including any physicians that you work with. So just a quick summary of important key issues that I've covered so far. First of all, infants with abusive head injury can look completely normal from the outside. So we can see bruising, but we won't necessarily. We can see scalp swelling. We won't necessarily. Oftentimes these babies come in looking completely normal on the outside. So they are not presenting looking like children who have been traumatized, okay? And so oftentimes people are thinking of other medical diagnoses, and the possibility of abusive head trauma doesn't even cross their mind. In addition to that, the signs and symptoms can be vague, and I'm going to get to those here shortly, and they can be easily mistaken for a more benign problem. And because of that, abusive head trauma is sometimes missed or misdiagnosed by medical professionals. So I'm going to show some photographs here. These are not going to be in your handout, but I'm going to talk here for the next several minutes about bruising, specifically bruising in babies. And we're going to talk about the kinds of bruises that we should be worried about and the kinds of bruises that we don't need to be worried about. And our research tells us that bruising is the most commonly overlooked sign of abuse, and it's the most least understood when it comes to babies. And I'm going to explain this. There is a rule that you can hopefully remember easily and take away with you today called the 10-4 bruising clinical decision rule, okay? This was developed actually at Kosare Children's Hospital with one of our ICU nurses. She's a research nurse, and one of the pediatric emergency medicine faculty members. This has been published, and there's currently a 5-year NIH study going on to validate this prospectively. And if it goes as well as we think that as it's going to go, this will become a standard way to screen for abuse on the basis of skin findings. So the 10-4, TEN, stands for torso, ears, and neck. Now when I'm talking about torso, imagine one of those little old-fashioned plastic baby dolls and pluck the arms and legs off. I know, it's creepy. If you can think of a less creepy way to explain it, let me know afterward. But what you're left with is the torso. So it includes not just the chest and the back, but the buttocks, the genital regions. All of that piece is the torso. So bruising to the torso, the ears, or the neck in a child 4 years or younger is a positive screen, or, and it's the second part that's probably the most important for prevention of, or early recognition of abuse in babies, any bruising anywhere on a child 4 months of age or younger. Any bruising anywhere on a child 4 months of age or younger. And I'm going to show you some examples to kind of help demonstrate how that presents. Now this picture here is a little guy that has buttock bruising. You can see some subtle stuff on his low back, but you mostly just see sort of this linear stuff on either side of his gluteal cleft. Okay? Now oftentimes this bruising gets mistaken for being a sign that something linear was used, like a belt or a cord, because it's shaped in a line. But actually this distribution of bruising on little kids' bottoms is very, very common, even with multiple blows with an open hand. And what is happening there are the edges of the skin on either side of the gluteal cleft there, they're getting crushed or crimped together during the impact. So it's kind of like a corner is being created when the hand impacts the buttocks. Okay, so right underneath the hand, right where that bruising is, the skin is being crushed together. And so we see that linear bruising on either side there very commonly, and that can still be multiple blows with an open hand. Okay, so that is torso bruising. Little kids fall down on their bottoms all the time. They almost never get bruises there. Okay, certainly not in the distribution that you're seeing right here, okay, from an accidental fall. This little baby here, you can see the extensive bruising deep inside the ear. There's also some bruising on the side of his face. He unfortunately was kicked in the side of the head. He was a 7-month-old, and he had some bleeding inside his head associated with that. And then this child here, you can see it kind of looks like a shadow, but it's actually a bruise on the underside of his chin, on his neck, and then he has a corresponding one on his chest here. And this child was a victim of abusive head trauma. Now, we see this chin and chest bruising like we see in this picture actually sometimes. It's not super common, but when we see it, it's almost exclusively in kids who are victims of abusive head trauma. And we don't exactly know what's causing it. It may be that the chin is impacting the chest during a shaking event. It may be that the chest bruises are coming from the thumb of the perpetrator squeezing so hard they're causing bruises, and that the chin is impacting the perpetrator's thumb. We really don't know what the exact mechanism is, and we don't know why, you know, some kids get this and then many kids don't. And we see them on a wide variety of outcomes. So we can see them on the mildest cases, and we can see them on the fatal cases. So it's not necessarily an indication of how violent the event was. We don't fully understand it, but what we do know is that we don't see that kind of bruising when kids just fall down, go boom, you know, and hit a coffee table or fall downstairs, things like that. So I'm going to tell you a couple stories of these kids just to help demonstrate these rules. These are two examples of torso bruising. This first little gal here that has the pink pacifier up here, she was 9 months old, and her mom had left her in the care of her boyfriend for the first time overnight while mom worked third shift. And when she came home the next morning, the baby was awake, but she just was not quite acting herself. She was still making eye contact and taking her bottles, but she just wasn't herself. And when mom went to change her clothes, she sees this bruise on her belly, and thankfully was worried enough to bring her to the pediatric emergency department where I did my training. This was up in Wisconsin. And the baby actually looked great in the ER. She was sitting up, she was sucking on her pacifier, she let me feel her belly and didn't cry when I, tried to feel if there was a liver edge and all that stuff that we're doing. But because she was a baby and she had a bruise, we did the full workup. We did a complete skeletal survey, we did a head CT, and then we also did trauma labs. The trauma labs that we do are liver and pancreas enzymes, AST and ALT, amylase and lipase. Okay, now those will not pick up every intra-abdominal injury. You can have hollow organ injury, to the stomach or the intestines, and there unfortunately isn't a lab that will check for that. But these are sort of a way to at least screen. Well, her skeletal survey was normal, her head CT was normal, her pancreatic enzymes were normal, her liver enzymes were through the roof. They were in the thousands. And this was a baby that looked fine. I mean, she let me smush on her belly. We did a belly CT, which is what we do when those trauma labs screen positive. She had a grade 3 liver laceration. So she went straight to the ICU with that. Now, if we hadn't caught that, probably she would have healed that injury herself if we had sent her home. But she would have been right back in that dangerous environment, and she may very well have come back the next time dead. Okay? So even the tiniest, most subtle bruise on a young baby needs to get our attention. Okay? This was a little girl who was less than a year of age, but this is torso bruising. Even though she was crawling, this is not the area that we see bruised in kids who have become mobile. This little guy was discovered as the result of a domestic violence call. A neighbor at an apartment building had heard the couple next door fight a lot, and that wasn't necessarily a new thing. But this time he heard the baby cry in a way that really alarmed him. And so he called 911 and he told them, you know, I'm calling about the fighting, but mostly I'm just worried about the baby. So because he said that, police and Child Protective Services responded together to the scene. And it was a fairly typical response when, you know, the couple opened the door. Oh, everything's okay, officer. It was all just a big misunderstanding. You know, sort of a typical minimizing of what had gone on. But because they knew there was a baby there, the social worker asked to see the baby. And, you know, they were like, well, you know, he's asleep in the back. Do you really need to? And she's like, yeah, I need to. And so they take her back with the police officer to the back room. The lights are out. The baby's wrapped in a blanket, asleep in the crib, taking a nap. And she says, I need to do a skin check on the baby. And they're like, oh, come on, he's asleep. Are you really going to wake him up? She said, yes, I'm really going to wake him up, and I need to do a skin check. So she has them turn on the lights, and as she's unwrapping the blanket and starting to unsnap the sleeper, it's kind of occurring to her that this baby's not waking up. You know, he's not arousing to the light and to being undressed the way a typical baby would be expected to. And she sees all of this, I'm trying to get my mouse back here, here we go, all of this bruising on the torso here and here. This is all kind of blotchy and sort of petechial. He actually has some down here that's linear. It's actually shaped like a line, and so that may very well be related to a belt. But she asked, what's this on his belly? And the mom said, oh, he just got a new sleeper and he broke out, which I think is actually a pretty good on-the-spot, you know, lie to make up. But this worker knew better. She had gotten training about bruises in babies. She knew that this could not be ignored. Plus, it was becoming more and more clear that this baby was not waking up. He was breathing, but he wasn't arousing. So they called 911. He had a grade 2 liver laceration, a pancreatic contusion and laceration, and a duodenal hematoma. So a big collection of blood right around the part of the intestine that exits from the stomach. So he had life-threatening intra-abdominal injuries. If she hadn't come in and done that skin check and found those bruises, he would have died in the crib. There's really no question about it. And how many public health nurses are in homes that have the opportunity to do this kind of skin assessment? Now, I understand that it may or may not be practical or even necessary to do this in every single case in every single family. But later on, when we're talking about risk factors, those are things that you can keep in mind when you're going into these homes or when you're interacting with these families, even in an office setting. The other thing to understand is that even if you are not seeking a skin assessment, if you're seeing a 2-year-old for shots and the mom's sitting there holding a 4-month-old who has bruising on her cheeks or her neck, that needs to get your attention whether you're seeing that baby or not. Okay, so these are things that you can watch for. This picture on the left is just more example of diffuse torso bruising on a child that was physically abused. She was also burned, unfortunately. This is another, I think, very, it's an unsettling example of how minimal the bruising needs to be an potentially evidence of severe internal injury. This was a 6-month-old whose mom noticed blood in his diaper that she thought was mixed in with his urine. It was fairly subtle, so she wasn't really sure if that's what it was. He was otherwise fine. He had no history of trauma. You know, she brought him in because he had blood in his urine. His physical exam was completely normal with the exception of these 2 tiny bruises. He has this one here over his back and then this one here over his left flank. And because of this bruise here, and because this is bruising in a baby, the full workup ensued. He got a skeletal survey, had CT, and the trauma labs. Actually, the trauma labs were normal from an AST, ALT, amylase, lipase, but part of the trauma labs is to get a urine, not a cath urine. If you do a cath urine, you're going to introduce blood into the urine just by using the catheter. So this has to be a bag specimen. But he did have blood in his urine. And so because of this bruise right here on his flank, they did an ultrasound, and he actually had a renal contusion under there with a tiny, tiny little laceration associated with it. So he had had a direct blow to his back, which had happened by his babysitter. It was an in-home child care person who had done this. And that's all he had on the outside. So this was not a baby in extremis or who needed intubation or who was screaming and crying. He was fine, except for these 2 little bruises. But because the docs who saw him and the nurses who saw him, number 1, did a skin assessment and found the bruises, and number 2, understood what a big deal these bruises could be, they did the full workup. And he ended up having the renal injury. He also had healing rib fractures, so he had been injured in the past as well. And then we have ear bruising. And the longer we study this, the more we're learning that this is actually pretty darn specific for abuse. It doesn't have to be abuse, but when we see it, it's more often abuse than it's something else. So we need to evaluate that child further. By the way, that's the way this 10-4 bruising rule works. It is not a diagnostic tool, it's a screening tool. So if a child has a positive screen for the 10-4 bruising rule, we need to look closer, but it's not necessarily independently diagnostic of abuse, okay? The bruising to the ears, it's actually pretty hard to get a bruise on your ear. If you have any doubt, sometime when you're bored, which I'm sure is often for all of you, that I'm sure have nothing better to do than to sit around and squeeze your ear, but try to squeeze your ear hard enough to give yourself a bruise and see if you can accomplish that. I've never been able to. Now, the mechanisms can vary. This little guy right here was actually picked up and thrown by his ear. This little girl here was actually hit in the ear, and you can actually see some bruising and contusion on her scalp as well. Now, she was in the ICU also with a liver laceration and a number of other injuries. But when we see ear bruising in any age child, but especially 4 years of age and younger, we need to take that very seriously. We need to get a detailed history. Now, once children are mobile and they're up, cruising along and running around, they can fall on things and hit their ear, but it's uncommon. You have to hit something with a pretty sharp edge or catch it, because the ear is in what we call the protected triangle between the side of our head and our shoulder. When we fall down, we're more likely to hit the side of our head and our shoulder. Everything inside of that tends to be protected. Now, even in my house, my youngest child bopped his older sister with a foam covered baseball bat, but the little plastic piece on the end got her in the ear, and she got an ear bruise from that. And I witnessed it. So, yeah, that was technically an inflicted injury, but it was inflicted, by a 3-year-old. So, again, it's not independently diagnostic, but we have to have a clear history for it. The more extensive the bruising it is, especially if it's bilateral bruising or if the bruising extends to the side of the head, we need to take that very, very seriously. And those children may need to have imaging of their brain to make sure there's not additional injury inside their head. These are examples of neck bruises. These look a lot like the bruises under the chin that I showed you earlier on the child who was a victim of abusive head trauma, and this child is too. Unfortunately, this 2-year-old died as a result of his abusive head injury, but these pictures were taken while he was still in the ICU, and you can see bruises on either side of his neck there. Definitely not locations that we typically should be seeing bruises in mobile kids, certainly not babies. This little guy, I think, was about 9 months old. His mom took him to the doctor because she thought he had an ear infection. Didn't say a word about all this bruising on the side of his neck. The doctor asked about it. She said, oh, he fell asleep on a Lego and woke up with that. Now, if any of you have any doubt about whether sleeping on a Lego can cause this, unless he has a really bad bleeding disorder, which even hemophilia kids tend not to do this. This ended up actually being an attempted strangulation is what caused these bruises. But this is a protected area of the body. This is not an area that gets injured accidentally very commonly at all. And then one that I think is most important as part of this bruising rule is that any bruising in any baby 4 months of age or younger, okay, that needs to prompt a full, thorough evaluation for abuse. And I'm going to talk more about what that involves, but in short, head CT, skeletal survey, trauma labs, and then we also do bleeding labs, as well, to make sure that we're not misdiagnosing a child with a bleeding disorder as having been abused. That also is part of our job in child abuse pediatrics, is to make sure that not only do we not miss any cases of abuse, but it's equally as bad, probably even worse, to call it abuse when it's not. Okay? So part of our job is to help make sure that we're not doing that, that we're identifying all the other mimics of abuse that may be there, so that we're not accusing families when that's not really what's going on. This little guy on your left he was about a month old, 5 weeks old, came into the pediatrician's office for a checkup, and obviously this is an umbilical hernia right here. Just ignore that. That'll go away with time. But the thing you're supposed to actually pay attention to are the two little bruises down here. Mom had no complaints. The baby was growing and eating well. The doctor really had no concerns until she did her exam and saw these bruises. And she had actually just finished her residency at U of L in Kosare. She was 3 months out from her, so she was brand spanking new as a pediatrician. And she saw these bruises, asked Mom about them, and she said, I don't know, I hadn't noticed them. And that was really the extent of the explanation. So she sent the baby to Kosare, and it was actually a little bit of a trip. It was about a 40-minute trip. She wasn't right in Louisville. And the baby had somewhere between 4 and 6 healing rib fractures and metaphyseal fractures. So this baby was clearly not just recently abused from the bruising, but had some bony injuries that were at least a couple weeks old. And we did our evaluation for bleeding disorder and bone disease, and he didn't have either one. He was clearly an abused baby. So by her identifying just these two tiny little bruises, she saved his life. There's no question about it, because he got identified, he got protected. He's actually since then been adopted out and is thriving. You know, the good news about him is that his fractures and his bruises healed, and his brain was still intact, and he's a normal little kid now. If she hadn't found and identified these early warning signs, who knows what condition he would have been in the next time he came in, okay? Almost the identical story here on this little guy. This was a 4-month-old, one little bruise on the back of the thigh. That was it. That was all that was identified on exam. They sent him in to the ER to have the full evaluation. He had multiple fractures, okay? Again, on this little guy, his brain was okay. So because they noticed these very subtle signs and sent them for evaluation, the kid ended up being protected. Now, as all of you know, there are certain bruises that kids earn and will have all the time that are accidental, okay? And I think most of us actually have a fairly decent sense for what these are. But first of all, one of the rules to remember, and this isn't printed on your slide, and it should be, is that those who don't cruise rarely bruise, okay? Now, cruising is what we call the developmental stage, where kids pull up on furniture and start taking steps along furniture. That's cruising. It's right before you start walking independently, okay? And when we study large populations of children, of young children, what we find is that it is incredibly rare for children to have, babies, to have any bruising at all, anywhere, until they start pulling up and cruising. Once they start doing that, they start falling, and they get bruises typically on the front side of their body, because most babies don't move in reverse. So they get them on their foreheads, they can get them on their elbows, but the one that takes, the area that takes the brunt of it is the knees and the shins. And you've all seen this, you know. I mean, on my 4-year-old at home right now, I bet he has 30 on each shin right now, and that's a given, especially in the summertime. So bruises on the fronts of the body over bony prominences. So bony prominences are where we have skin right over the top of bone. Knees, shins, forehead, elbows. Those are the areas that typically get bruised from accidental injury. The back side of the body is much less common. Now, in older, more mobile kids, we've seen kids go down the steps on their bottoms, and they'll get little bruises over their spinous processes, over their lower back, where their back kind of scraped on the way down. Buttock bruising, still incredibly rare. So even in children who are up and mobile, falling on their bottoms, the little ones, the toddlers, tend to have diapers as padding, plus any clothing that's on top. The only exception to the bottom bruising that I've ever seen that I really felt like was actually accidental, it was just a tiny little non-specific cluster of bruises in one little area, like an inch big, and a 19-month-old had been standing in the tub and fell on her bottom on a plastic truck that was in the tub. So you can sort of see how that's a little bit of a special circumstance. She didn't have a diaper there to protect her. She was falling against a really hard surface of the tub that had something that would intrude and cause that bruising. So just a summary of everything I've talked about with bruising so far. It's extremely rare in any child who's not yet pulling up and cruising. So the 10-4 bruising rule says 4 months and younger. This slide says 6 months of age and younger. So which is it? The truth is it really has very little to do with age and everything to do with developmental level. So if they're pulling up and cruising, they are ready to earn their bruises. If they are not, we need to be very concerned about any bruises anywhere. Okay? This is a significant indicator of abuse. It has to be reported and it has to be medically evaluated, and that has to be done promptly. Okay? And when I say promptly, I mean emergently. And a lot of people raise their eyebrows at me when I say that, including doctors. Because it seems like a huge waste of medical resources to a lot of very reasonable people to send an otherwise well-appearing baby or young child to the ER just because of some little bruises. But what we have learned is that if we don't, we miss the opportunity to protect these kids. We had a fatality in the Louisville area a couple years ago of a 9-month-old little girl who had been brought to her pediatrician twice by her mom because of unexplained bruising on her arms and legs. No history of trauma. The mom seemed very nice and well bonded, so the pediatrician never even thought about abuse as a possibility. But this is a 9-month-old. She wasn't cruising, and these were bruises on her arms and legs. So he set her up with an outpatient referral to hematology oncology because he thought she probably had a bleeding disorder to explain this. And she was killed before she made it to that appointment. Okay? So this is not something we set up as an outpatient to get a skeletal survey Tuesday of next week. Okay? When we see bruising on babies, we send them to the ER. Now, not every medical facility realizes this is what they're supposed to do. We may send a baby to the ER. You as a public health nurse may try to do that. And the ER doc's like, what am I supposed to do with this kid? And we have to tell them. Okay, so we have to kind of step up to the plate and have difficult conversations to say, well, this is the training I've received. This is what my understanding is of the degree of workup that needs to happen. And if that doesn't work, if they aren't receptive to that, then call us. We're on call 24/7, 365 in Louisville. You call COSAIR's main operator number. It's at the end of your handout, I think. And you ask for the forensics folks. And you can pass the phone to the ER doctor. And we do that sometimes. And we'll say, hey, I'm Dr. Curry with forensics. Nice to meet you. What do you have? And we try to, gently and professionally and respectfully guide them to doing the appropriate workup. Okay, any questions about bruising or anything I've talked about so far before I start talking about how these kids come to our attention? Please feel free to ask. Don't be embarrassed.
Hang on just a minute. Go ahead.
I was wondering if you could touch on Mongolian marks for usually minority children. A great deal of my Mongolian marks are being mistaken for bruises and abuse, being infants.
That is a great question and comment. I didn't see which county that came from. What's that? Bullitt? I think that came from Bullitt County. But thank you for that comment. She asked me to talk about Mongolian spots or Mongolian marks. These are also known as slate blue nevi, and they're basically birthmarks. They're much more common on African American, I guess really the best term is non-Caucasian kids, because kids from East Indian, Pacific Islands, African American, and Hispanic kids all are have higher rates of having this. And they look bluish gray, and they tend to be over the low back and the buttocks, and they can very easily be mistaken for bruises. There are a couple things that we can do, both when we're assessing those and also to try to prevent these families from having to go through CPS when people see this on their kids. If you're in the position and you think that this may be a Mongolian spot, the easiest way, to assess this is to see the child back in a couple of days, because if it's a bruise, it's going to change in size and color. Mongolian spots stay the same. Obviously, the other easy thing to do is to ask the parent, what is this? And if they say, oh, she was born with those, that's pretty reassuring. We're trying to encourage doctors and nurses who see these to document those and to let the parents know, hey, whenever you have a new babysitter or daycare provider or anybody like that, make sure you tell them about this, because people will mistake it for bruises. We probably get at least one referral a month for people who think it's bruises on babies, and it ends up being Mongolian spots. So that is very common. I hope that answers the question. Any other questions?
Yes, I have a question. You haven't discussed about forehead hits, what they call shiners. I had an issue. I'm an oldie-moldy public health nurse, and I had an issue with that years ago. Mother could not get a good explanation. It was the baby was in a crib in a room. It was a pass-through where lots of people went through. She said she just went in there and got the baby up and saw them. She could not give me an explanation. And I called DCBS right then, and they came over.
Very good.
Can you elaborate on that?
I sure can. One thing that can happen in older children who are mobile enough to get a bonk on their forehead, which again only happens once they're able to cruise. If they can pull up on their crib, then they can hit their forehead on the edge of the crib or the coffee table or whatever. So if this is a young baby, this is still very concerning. But for older children, when they get goose eggs on their foreheads or their upper scalp, with time and gravity, oftentimes, if the child's brought into the doctor's office because they just fell and they have a goose egg, we warn the parents, tomorrow morning they're probably going to wake up with 2 black eyes, because that blood tracks down and it tracks through the tissue planes. That's actually called ecchymosis. Ecchymosis is when the blood from a contusion leaks and shows up in other places that weren't actually injured. So if you have a forehead bruise and contusion where it's sore and you know there was an impact there, you can have ecchymosis in other places. If that's a 4-month-old, I'm still going to be really concerned. If that's a 24-month-old, I'm not going to be as concerned. Okay? Does that answer your question? Sorry, I'm making her get up.
Yes, it does. This was a 1-year-old, but there was no goose egg on the head. There was no external trauma other than the 2 shiners.
Okay.
And the baby was a 1-year-old or just slightly less maybe. And so I didn't see anything other than the black eyes.
Okay. I think you did the right thing. I think calling DCBS and getting the child immediately for medical care. Another thing that 2 black eyes actually can be, or what we call raccoon eyes, periorbital ecchymosis. Sadly, that can actually be a presenting symptom for a couple different kinds of cancer, okay? I'm totally blanking on the kind of cancer it is. Medulloblastoma can present with raccoon eyes and bleeding around the eyes, and we really don't completely understand why that happens. But there are potential medical causes for that as well that also need to be worked up immediately. Other questions?
Yes, I have a question.
Okay.
I just want to be clear about what we're supposed to do. Say we go into a home. I'm a nurse, and say I go into a home and I see a baby who is not cruising with a small bruise. What are you saying I should do? What are you saying I should do?
I understand. I was going to get to more of those details later, but I think this is a perfectly good time to talk about it. I haven't actually told you exactly what you should do, so I can understand your confusion. What you need to do is document it, and you need to talk to the parents. And this is sort of the spiel that I used when I was doing general pediatrics, so anything along these lines would be fine. is Mr. or Mrs. Jones, I know that, this isn't the reason that I'm here today, but I'm noticing bruises on your 4-month-old. And believe it or not, even though she looks great, from the training I've had, that can be a sign of something serious. You don't have to say it's a sign that you or someone else has abused the baby. All you say is it can be a sign of something serious, because that's true. This could be a baby with, heaven forbid, a new cancer or a bleeding disorder that hasn't been diagnosed yet, or any number of other things. And what you say is, based on the training I have, babies this age with bruises need to go directly to the emergency room. So I would strongly urge you to take the baby to the emergency room. And let them know that you're going to call ahead, and let the ER know that you're the public health nurse, and this is what you saw, and this is what you would anticipate them doing. If you don't get a lot of support, either if the family is resistant and doesn't seem to believe you, then you call CPS, and you document everything that you said and what they said in response. And then it'll be up to CPS and police to go get the baby and bring them in for evaluation. Now, the second hurdle after getting CPS and police to go get them and bring them in for evaluation is getting the local hospital to understand what they need to do as far as an evaluation. Again, that's part of what we can do to help with, but the workup is also in your handout, and you can literally just take that with you or talk to them too. But you have to intervene in some way. I think talking to the parents directly, trying to encourage them to go to the ER, call the ER and tell them about your concerns, document all of those findings, and then whether or not they follow through on your request, I'd go ahead and call CPS. If the ER finds a bleeding disorder or something else, then it's very easy for them to tell CPS, never mind, you can finish up your investigation and close the case. But at least then you haven't missed a mandated reporting opportunity. Now, what you cannot do is kidnap the baby and take them to the ER, as much as you might want to do that. That's not okay. So you kind of do the best you can. Does that help?
Yes. So you're saying that we would encourage the parents to take the child to the emergency room and notify CPS.
Yeah, I would. Here's sort of the subtlety of that. Depending on your community and what resources you have available, if these are issues that you can address beforehand, before it actually occurs the first time, you can find out if your local ER understands what to do. If they do, then and the parents appear to be willing to go to the ER, you can wait and not call CPS unless either they don't show up at the ER or if the ER doesn't find some other medical explanation. But you have to know for sure that you've got an ER that'll follow up with you. If you don't have that situation, you're better off just calling CPS, at the beginning. Okay? Other questions?
Go ahead.
Yes. Are there any plans for educating ER docs on this?
Yeah, I wish. So here's one of the dirty little secrets about House Bill 285, and that is that it was dead in the water, literally up until the night before the session ended last year, until they removed the requirement for doctors to get this education, because sadly the doctors have, I can say this because I'm a doctor, I can get away with this, they have a lot of political pull in the state, and it's incredibly disappointing to me that this happened, but the bill wasn't going to get passed at all if they didn't take it out. So unfortunately, as of right now, the physicians in the state are not required to get this education. Now, there are a large group of them who still care about their job and care about kids and want to learn it on their own. They want to be aware of that. And so we are developing presentations for physicians and making that available. We're also trying to write in the medical journals and stuff that the physicians read. But sadly, no, there are no formal plans to get this out, and there are no formal requirements for them to get this training. So again, there's a large burden on your shoulders and the shoulders of the other nurses in the state who, when they see this, have to bring it to the attention of the docs and do the best that they can. Other questions? Questions from in here? Okay. Feel free to interrupt if you think of anything else, but I'm going to go ahead and start talking about how these babies present for medical care, what they tend to look like, and what their most common symptoms are. Well, I've already talked about bruising. I'll try not to belabor that too much, although it is a really important one. The other one is vomiting in the absence of diarrhea. Now, before you have a heart attack, don't worry. I am not going to tell you that every child with vomiting in the absence of diarrhea has to go to the ER. Okay, obviously that would be completely unreasonable because every baby with reflux in the state would end up in the ER, right? And doing a head CT on those babies would be highly inappropriate. But the babies for you to think about are the ones that maybe have been back every day for 3 days in a row. There aren't other people at home that are sick. The baby still hasn't developed diarrhea. Feel the anterior fontanelle. If the fontanelle feels full, that's a concern. You know, when a baby's throwing up, usually they're getting dehydrated, and if anything, that soft spot is going to be sunken. So if you have a bulging fontanelle or even a full or tense one, if the baby is vomiting and a little bit irritable, or vomiting and a little bit sleepier than normal, those are the ones where your antenna should start going up. And you can direct the family, depending on your role, either to their pediatrician or to the hospital to get further evaluation. And again, feel empowered to call the doctor, whether it's calling the pediatrician or calling the ER or the urgent care and saying, this is why I'm sending them to you. Based on my training, I'm concerned about something going on inside the baby's head. Now, anything that increases intracranial pressure can do this, can cause vomiting in the absence of diarrhea. So it's not necessarily head injury or inflicted head injury. It can be a tumor, it can be an aneurysm, it can be hydrocephalus developing, it can be a number of other things, all of which need to be diagnosed promptly. So just kind of keep your radar open for that one. One of the most common presenting scenarios for abusive head trauma, and probably the most missed one, is what we call the ALTI. ALTI stands for Apparent Life-Threatening Event. And what happens in an ALTI is that a baby has some sort of episode with the caregiver that scares the caregiver and makes them think the baby's life is in danger. So either the baby goes limp, or stops breathing, or turns blue, or maybe does something that looks like they're having a seizure. Maybe they make some choking sounds before all of this, whatever. The parent either puts them in the car, or the caregiver puts them in the car, rushes them to the hospital, or they call 911. But by the time the baby gets to medical attention, the baby looks fine. Okay? Now that's what distinguishes an apparent life-threatening event, or an ALTI, from a life-threatening event. Because if they still look bad when they get to the ER or when EMS gets there, if they're still limp and unresponsive, well, that's just a life-threatening event. That's a whole separate kettle of fish, and that also can be abusive head trauma. But the apparent life-threatening event are these transient symptoms. And one of the things that we see happen is that, number one, EMS, if they get to the home or the site and the baby looks good, they'll say, okay, well, never mind. We'll leave, follow up with your pediatrician. And the kid gets no workup. Or the child's taken to the hospital, but because they look good in the ER doctor says, well, she looks fine now. I guess we don't need to do anything. Let's watch her for, you know, a half an hour and see if she takes Pedialyte, and we'll send her home. And what we're learning is that of all the things that can cause this, and there's a long list of things that can cause babies to have these kinds of episodes, everything from reflux to seizures to, you know, heart problems. But of all of the things that can cause these events, abusive head trauma is the most common one that we're going to find. So it is now standard of care nationwide. Part of the evaluation for an apparent life-threatening event in a baby is a head CT. Now, if that head CT is normal, you don't have to do anything else. You don't have to go on with the skeletal survey or anything else. But what you're looking for is evidence of something going on in the head to make the baby behave the way they behaved. Now, we have to use our common sense, our physical exam, the history. If this is a baby that has been throwing up since birth and has terrible reflux that's been diagnosed by a GI doctor, then no, we're probably not going to do a head CT on that baby, you know, for a while unless we don't find anything else. But this is an event to be aware of, and you may be in the position of having a family tell you that this has happened to their child, and either they called 911 or they went to the ER and the appropriate testing wasn't done. You can ask, did they do a head CT or a scan of the baby's head? And they'll say, well, no, they gave him a bottle and he held it down, and so they sent us home. So you can then call the pediatrician or whoever the family practice primary care person is, nurse practitioner, whoever, and say, hey, I'm concerned. This is what I've just been told, and from my understanding, that can be a sign of head injury. You know, I think that there needs to be further workup. A lot of this intervention and early recognition that all of you do is going to then be followed by you using your very best communication skills with other professionals to let them know, this is who I am, this is what I'm seeing, this is what I've been taught, I need your help now to get it, you know, to happen further on down the road, to make sure that the medical evaluation happens, and if necessary, CPS to be called. Now, if we do the head CT and there's nothing there, we don't have to call CPS for every baby with an apparent life-threatening event. But obviously, if we find something, then yes, they need to be called. A sudden increase in head circumference is another big one, and we oftentimes see this in retrospect. One of the most common scenarios we see is a 5-month-old comes into the hospital either completely unresponsive and not breathing and ends up in the ICU with severe head injury, or the 5-month-old comes in with vomiting in the absence of diarrhea or an apparent life-threatening event. And we'll get that child's pediatric primary care records because I realize many of the kids in the state of Kentucky don't have a pediatrician. They either have a family practitioner or a nurse practitioner. But we get those records, and the baby's head circumference has been, 25th percentile, 50th percentile, somewhere in that ballpark. But then when they had come in for their 4-month shots, their head circumference had jumped to either 75th or 90th or off the charts. They had crossed 2 major percentiles. That should be an indication to do further evaluation. That can be a sign of various kinds of head injury. It can also be a sign of hydrocephalus, a sign of brain tumor, a sign of anything that's increasing the pressure in the head. So oftentimes these children come in and have had a sudden increase in head circumference that should have been a clue to somebody, and it got completely overlooked. So one of the bad habits, and I used to be guilty of this as well before I started doing child abuse, is, the child comes into the, primary care office, they get their head circumference measured by the nurse, and then whoever is seeing the child, nurse practitioner or doctor, never even looks at the head circumference, never even plots it to see where it ended up. We have to actually look and pay attention to that. So if you're the one that's measuring it and plotting it and you notice that it's taken some big jumps, do something about that. Talk to whoever it is who's involved in that child to make sure they get some further evaluation. That may be a head CT, it may be an MRI, it may be following the head circumference. It just depends on the child and the head circumference. I just realized I failed to say something really important about the apparent life-threatening event. I talked about that the most common thing that we find when we look for something to cause the apparent life-threatening event is abusive head trauma. What I forgot to say is that what that is concussion symptoms. Okay, so when the baby goes limp or turns blue or is temporarily unresponsive, that's a baby with a concussion many times. And as we know from sports-related concussions, sometimes you can get a bad blow to your head and get a concussion, but then you wake up and you're gradually getting better and better. Other times you get a bad blow to your head and you don't wake up. And that's what happens in these babies, is they can be shaken, they get a concussion, so they stop crying. So the shaking actually kind of worked to stop the crying. And over time that escalates. And it can escalate first to an ALTI, to an apparent life-threatening event, and then if it happens for a little longer or a little harder, we really don't know what all the components are that tip the baby over into getting severe brain injury that's permanent, then they can come in pulseless and non-breathing or having seizures or things like that. So when we hear about these apparent life-threatening events, oftentimes it came out of the blue. They say, she was crying, I picked her up to give her a bottle, and all of a sudden she went limp. Well, they're leaving out the part where they got frustrated and shook her. Okay? So those apparent life-threatening events are actually concussion symptoms. Okay. I mentioned the head circumference. Sometimes these kids come to our attention just because we accidentally find a fracture on an x-ray that was done for some other reason. So we get a few more of these in the winter time than we do in the summer because so many babies with RSV are coming in and getting chest x-rays, and we find the healing rib fractures on chest x-rays. So that will prompt the hospitals to send these kids to us for review and to call CPS. And then sometimes it's developmental delay. You know, the child's 18 months and still not using any words, or it can be gross motor delay, language delay, it can be any number of kinds of delay, and then an MRI of the brain shows evidence of previous injury to the brain. So the severity of the symptoms can vary with the severity of the head injury. So it can be vomiting, which can be a very common symptom of childhood. Irritability also can be common. It can progress to be a little bit more significant. Lethargy, being difficult to arouse, sleeping more than usual, sort of sluggishness or seeming spaced out. Sometimes caregivers will tell us that the baby just wasn't focusing on faces the way that he usually did, or watching people move across the room the way he usually did. And then it can progress to more serious things like seizures and apnea, gasping respirations, and the heart can actually slow and stop as well. Now, I've talked about most of the medical evaluation. I just wanted to have all of it on one slide for you so that you had this for future reference. There are a couple of things I want to mention about this. I've already talked about the head CT. If there's anything abnormal on head CT, we have to follow that up with a brain MRI. Brain MRIs are much, much more sensitive for the brain injury itself. A CT will show us blood around the outside of the brain, but unless the brain is badly injured and swollen, it's not going to show us that there's an actual injury to the brain. Now, the MRI might not either. You know, for example, if a football player gets hit on the field and has a concussion, now they've obviously had an injury to their brain or they wouldn't have lost consciousness. But if you took them and put them through a CT scanner or an MRI, 9 times out of 10 that's going to be completely normal. So there are injuries to our brains that cause symptoms that we won't necessarily see on imaging, all right? But if we do have an abnormal CT scan, whether it's bleeding or swelling or a fracture or anything else, we have to follow that up with an MRI. The skeletal survey I've also mentioned. Just a couple of more words about that. This is a very specific study that is done close up. It's 19 to 21 different images of all the different bones in the baby's body. This is not the same thing as a babygram. So if you hear somebody use the term babygram, or if you see an image of the x-ray where they had the baby on the table and the x-ray beam 3 feet in the air and they took one shot of a whole baby, that has no role in the workup of abuse whatsoever. I have seen completely normal babygrams, but once you cone the image in and you get close enough to the bone to actually see the detail, you can have broken bones all over the place. Okay, so babygrams miss fractures. They have no role in the evaluation of abuse. Now, the other thing that I mentioned already when I was talking about rib fractures that's important is that follow-up skeletal survey in 2 weeks. So even if they get one skeletal survey that's normal, let's say we have a 6-month-old with bruising that's unexplained, and we do a skeletal survey, it's normal, we do the head CT and it's normal. We may still want to keep that case open and do a follow-up skeletal survey in 2 weeks. We may also decide to do a bone scan, which is a different kind of study. It's a nuclear medicine study, and it can pick up on rib fractures before they've started to show signs of healing. So if we have a young baby that we think is really vulnerable and nothing else is showing up, sometimes we'll go ahead and do a bone scan rather than waiting the 2 weeks for the follow-up. Anytime we have abnormal imaging inside the head, we want to do an eye exam. There are some centers that will do an eye exam whether the head CT is normal or not, if there's any suspicion at all for abusive head trauma. We do the trauma labs and the bleeding labs to screen both for internal injury and for bleeding disorder. And then, of course, we photograph all visible injuries whenever that's possible and call DCBS immediately. Now, I've already mentioned that not all medical facilities or medical providers are equipped to do these kinds of evaluations or even are trained to know that they need to be done. So again, I just want to reiterate that regardless of your role in the process, please feel empowered to advocate for your patient and for the family to make sure that this kid gets the workup that they deserve. All right, so we're going to move into talking a little bit about outcomes.
Excuse me.
Sure.
Excuse me. You had said that we could call a number if the doc didn't want to do anything or didn't know what to do, and you said it was in the back of the slide, the handouts, but it's not. Could you?
I lied. I'm sorry. Everybody grab your pen. It's area code 502-629-6000. So 502-629-6000. If you lose this, just Google Cozaire Children's Hospital in Louisville and call their main number. That's what that number is. And you ask for the child abuse people on call. And there is always somebody on call for us. Okay? Thanks for asking that.
We can add it to the minutes.
Okay.
Minutes come out and go
All
out
right.
from the meeting.
She said she'd add it to the minutes as well. Any other questions or comments? Okay. So once this kind of injury has occurred to a baby or a young child, what tends to happen? Well, it's basically broken into thirds. A third of these kids die. A third of them are severely permanently disabled. And a third of them do relatively okay. They can have some mild disabilities, but they become, functional, relatively productive members of society by, our typical definitions. When you take the group of children who survive, nearly 90% of them will have some identifiable disability. It may be mild, but only about 10 to 15% of these kids escape this kind of injury with nothing when you do ongoing developmental assessment of them. Now, the disabilities really run the gambit. They're all over the place. They range from physical disabilities, cognitive, language, emotional, behavioral. It can really be any portion or all of those different categories. One of the things that we've just learned recently to start screening for are hormone and growth problems because of pituitary injury. So I think probably many of us who have interacted with children who either had hypoxic ischemic encephalopathy from, being anoxic at birth or hypoxic at birth, who are wheelchair bound and have cerebral palsy. I think many of us who have interactions with those kids are aware that they often don't grow and gain weight to the same degree as children who don't have cerebral palsy. And it turns out that in many of those cases, it's because they had pituitary damage. So if we replace some of those hormones, sometimes we can improve those children's quality of life. Now, there are obviously some ethical issues too. If you have a single, caregiver who's a small woman, for example, you don't want her 17-year-old son weighing 150 pounds if she has to transfer him from the wheelchair to the bed to the tub every day. So there are other things that you take into account. But if it will help the child's cognition or quality of life, then that is definitely something for us to keep our eye on and to screen for and to treat when it's indicated. The severity of the disability really ranges. It can be mild and subtle all the way to a permanent vegetative state, and really research is ongoing. We're just now starting to sort of get a handle on the spectrum of disability that we can see from this kind of head injury. Once a child has been identified as a victim of abusive head trauma, it can be a real challenge to get them the kind of ongoing long-term care and support that they need. And this is complicated by the fact that oftentimes they're removed from their previous caregivers, whether they're removed from their home and placed with family members, or whether they're completely removed and placed in unrelated foster care. This changes oftentimes where they go to the doctor. If it's foster parents, oftentimes, as you know, foster parents aren't told exactly what has happened with the child. And so this child is taken to a new pediatrician, and the pediatrician may or may not have any idea what has happened. So one of the most important things is to try to establish a medical home as soon as possible after discharge with whoever is now going to take care of the child, and make sure they get a copy of the discharge summary from the hospital. If forensics has been involved, if we've been involved, giving them a copy of our report, because we put recommendations about long-term follow-up for these kids as well into our reports. Now, The other thing that can happen here is, the kids can be discharged to medically fragile foster care, and then they progress and are, within 4 or 5 months able to eat from a bottle and don't need their G-tube anymore, for example, and then they're moved from medically fragile foster care to regular foster care. So now they've been moved twice, and sometimes that happens 3 or 4 times, and each time that happens, the new caregivers take the child to a different doctor. So anything we can do to try to establish some continuity, communication between the different doctors' offices is so important. Another group of kids that get lost in the shuffle, unfortunately, are the siblings. Sometimes they are injured also if they're young kids, and that's definitely part of our responsibility. Is if we have a baby that's the victim of abuse, we make sure that if there are other kids in the home, they've all received the appropriate screening. The skeletal survey we tend to do 2 years of age and younger as a standard, and in select instances we can do it when they're older. Head CT kind of depends. If they're younger than a year, we do it. If they're between a year or 2, then we sort of have to use our best judgment. But in addition to also being victims of abuse, the older siblings sometimes have witnessed the abuse that led to their younger sibling ending up in the hospital to begin with. Sometimes they've been an ongoing long-term witness to violence in the home. Sometimes oftentimes they too are removed from their home and placed in a completely different home from their siblings. So not only have they lived with violence and saw their sibling get hurt, but now they've been separated from that sibling and may not know what has happened to them or how they're doing. As you can imagine, these kids need a lot of help and support and counseling and play therapy and observation and monitoring, and the truth of the matter is they very, very rarely get it. We just don't have the resources in most of our communities to provide that kind of support to the siblings. We tend to focus, as all of you probably know, on physical illnesses and disabilities, not so much on the mental and psychiatric side. So we need to remember to think about those kids and do everything we possibly can to advocate for them getting the services and the support that they need. And again, the same thing applies to them as to the children who are physically injured. Oftentimes they're placed in foster care or even in a distant family member's home who didn't realize what was going on in the child's primary home. And so people don't even know what has happened to the child to know that the child needs to have care. And then they end up having, disruptive behaviors or emotional problems, and then they get diagnosed with ADHD when they're 3 and they're on meds, but by the time they're 4, and it's sort of this vicious cycle of inappropriate medication because we didn't understand the child's history. So that's a whole big can of worms that we haven't even started working on yet. So the most common triggering situation for this kind of abuse, as I've mentioned already, is crying, but there are other triggers as well. A child's misbehavior, particularly when we're talking about older children and toddlers, oftentimes this is just discipline that has gone awry. And one of the things, I have this in a later slide, but one of the things that many of these cases have in common is unrealistic expectations of the child by the child's caregiver. So these are moms who smack a 4-month-old's hand when she reaches for something colorful. Okay, now all of us who have had any child development training at all know that a 4-month-old is not going to understand that means she's not supposed to reach for something. That is not a connection that a 4-month-old can make. So using those teachable moments to redirect the parent, and saying how dare you, or oh that's inappropriate, if you're condescending or harsh, they're not going to be able to hear your message. So you have to be supportive. Oh gosh, I understand how frustrating this stage is. They're always grabbing for something. Actually, that's a good thing. That's what she's supposed to be doing at this age. That means she's curious. Usually the best thing to do is just move it out of her sight and redirect her, or give her something she can hold. You're doing this in a kind and supportive way, not in an accusatory way. Toilet training in toddler-age children is another common inciting event. When a child has a toilet training accident, oftentimes abusive head injury will follow, and also this is one of the most common triggering events for abusive burns. So when we have toddlers that come in with burns to the buttocks or the genital areas, oftentimes it's because the caregiver had unrealistic expectations. They thought that you could potty train a 13-month-old. And when that doesn't work, in the process of cleaning the child up, they decide to teach them a lesson. And so oftentimes we see children with burns for that reason. Argument and family conflict. This sometimes happens in the course of domestic violence or a physical altercation, either where the child is struck inadvertently or sometimes the child is intentionally abused in front of another caregiver just as a form of psychological control and torture. And then discipline gone awry. You know, again, the unrealistic expectations, the folks that think an 18-month-old can sit through a 2-hour Disney movie, for example. You know, there are all kinds of examples of this. People who talk about their 6-month-old as though they're manipulative. You know, she waits until I do X, Y, and Z, and that's when she cries, or that's when she throws her food off her tray. And, you know, when you hear, sometimes people are just saying this to be funny. You can tell the difference. Other times people say it, and you can tell they mean it. They really think that that child is capable of doing that. And if you don't take that opportunity to help redirect, then you've missed an opportunity, potentially, to intervene on behalf of this child. There are certain things that these families have in common sometimes. I've already mentioned domestic violence and family violence, single parents, military families, unfortunately. This, you know, certainly in Louisville, we're close to Fort Knox, so sadly we're seeing this. Just as a little digression here, you know, we really have not figured out what to do to help these families. It's very hard on the parent who is left behind to be a single parent when the soldier is overseas and deployed. It's equally as hard and maybe harder once that soldier comes back and tries to reintegrate into the family. That's called redeployment, when they come back and try to reintegrate. And, you know, what do we expect to happen when we send somebody overseas or wherever and they're living literally day to day, you know, fighting for their life, and then they come back home and their 3-year-old comes around the corner and says, "Boo, Daddy." What do we expect Daddy to do, you know? So I think in many ways we're just now starting to do the research that's necessary to figure out what interventions will actually help support these families and prevent these things from happening. This isn't, by the way, new. This is not a new generational problem. This has been around forever. This happened with Korea. It happened with World War I, World War II. It's just people didn't talk about it back then. But when you go back and you look and you talk to survivors, they will tell you that all of these same issues existed, you know, in previous wars and combat situations. So we really need to keep our eyes and try to support our military families as much as we can. Gosh, since the economy went south in 2008, we have so much unemployment, so much financial stress, you know, folks who have lost their homes in addition to losing their jobs. All of those things put stress on a family, and it puts stress on a caregiver and decreases their ability to be patient and to cope with a baby who's crying or with a toddler who's misbehaving. Isolation is a big one. I think most of us are aware of the isolation that occurs in the situation of domestic violence or interpersonal violence, where the victim is isolated from her family and friends as a form of control. But in Kentucky, too, we actually have geographic isolation. We have lots and lots of families, you know, who live miles from their closest neighbors. That in and of itself increases the risk, both because there's less support for the caregivers, but also because there are fewer eyeballs seeing those kids and seeing if they have bruises or other injuries that should be concerning. Poverty is certainly a risk factor, but certainly just because we live in impoverished conditions doesn't mean that we are or are mandated in any way to abuse our kids. Animal abuse is a particularly interesting one because with older children who are verbal, they oftentimes have been threatened and coerced not to talk about what is done to them and what kind of discipline happens at home. But what they will tell us about is what happens to the dog or the cat. And this it's heartbreaking, but it oftentimes opens the door to understanding what happens in a home that otherwise appears to be a quote-unquote nice family. And I'm going to talk about this nice family concept here shortly. Caregiver characteristics, I'm sure it is not a surprise to anybody to know that substance abuse and mental illness that is either untreated or undiagnosed plays a huge role in this dynamic. Criminal history among the caregivers in the home, poor impulse control. We see this in particular among the young men that we see as perpetrators. We're seeing a pretty significant rise in the babies crying interrupting a video game as being the inciting event. So they've been playing a video game for an hour and they're on a level that they've never reached before, and the baby cries and they get mad and they abuse the baby to get them to be quiet. And then teenage parents. I've already talked about the unrealistic expectations as being a common thread here. CPS history and prior removals, that seems like a no-brainer, but a lot of people are too shy to ask. My experience is that when it gets to personal questions about history like this, the more uncomfortable we seem when we ask it, the more uncomfortable the family's going to be answering it. But if we ask the question as though it's no big deal, they generally will answer it as though it's no big deal. You just ask it as though it's routine. You know, when you have a child in the birth, you know, just being born in the hospital, and that it's the mom's sixth child, and all 5 previous children no longer live with her, that's worth asking about. You know, it's worth finding out, why is that? Was that her choice? Was that the court's choice? Then, you know, it's very, very, you know, likely that that child is going to be at increased risk. And then caregivers that were themselves abused as children. This is another dynamic that I think is really heartbreaking at times, because we'll have a mom and a dad who seem both perfectly nice, and we have an injured baby, and one or the other of them will volunteer, I was abused as a kid. There is no way I would do this to my own child. You know, I understand what this does to a baby. I grew up with this. And what they don't oftentimes understand is that they're telling us, I'm the most likely person to have done this, because that's what statistics show. Now, that does not mean by any stretch that every child who's physically abused is going to grow up to abuse their own children. That's not the case at all. But if you compare those that were abused with those who weren't, those that were abused are more likely to be abusers. Okay? And then there are certain characteristics of the children themselves, okay, that make them at higher risk. Any child 3 years of age or younger, because they're tougher to care for. You know, they have behavioral issues. They're still learning to do basic things for themselves. They're dependent on us for our care, and they can't talk. They can't tell people what's going on with them. Drug-affected infants, very difficult to care for when they come home from the hospital. Oftentimes they're still withdrawing. On top of that, they very often have a difficult time with bonding, which really makes it tough to take care of them. You add to that that you may have a mom who's either an ongoing substance abuser herself, or she's trying to get clean, which adds a whole other level of stress to her life. And then she's trying to care for a new baby who's drug affected and fussy and not bonding well. It's a significant setup, and these are families, you know, and mom-child pairs that need a lot of support. Premature babies, those that have been in the NICU, those that have been in the hospital for a prolonged time after birth, multiples, twins, triplets, and more. Anything that makes the baby harder to care for. Any child with disabilities, whether it's physical or emotional behavioral, that includes autism. And then we have the unwanted child. Now, unwanted is different than unplanned. There are lots of unplanned kids out there, obviously, and many, many of them are loved and very much wanted by the time they get here, okay? But we all probably have some experience with, you know, the mom who offers to give you her baby. You say, oh, she's so cute, and the mom says, yeah, do you want her? Or you say, you know, do you have other children? No, this is my first and it's my last. You know, you sort of, and sometimes, again, people say this to be funny, and that's fine, but you can tell the people who mean it. You can tell the people who have some bitterness and hostility there underlying their voice, and you can tell they did not want this kid, they still don't want this kid, and they're really resentful that they're here and that they're part of their life. So when you come across those families, use that moment to intervene. You know, stop what you're doing, pull up a chair, sit down and look them in the eye and say, tell me what I can do to help you. That that really sounds like you're having a hard time with this, and talk to them about it in a supportive way. And you may very well be the person to help that mom understand, you know what, maybe she's not the one that needs to be trying to care for this child right now or ever for that matter. So unwanted children. And then one that I think is really interesting and unexpected is that children who are the result of infertility treatment and adopted children, particularly children who are adopted after many years of trying to conceive. We don't completely know why this happens, but these kids are at higher risk of being abused, and we think, again, that it has to do with the unrealistic expectations. That after, so many years of wanting the same thing, wanting to be a parent, it's completely normal human behavior to idealize parenthood. And then once we actually have the baby, if it's, number one, it's more likely to be a multiple if it's due to infertility treatments. But even if it's an adopted child, once we finally get the baby, if we're overwhelmed or if we find that it's hard, who are we going to talk to about that when everybody in our lives has just heard for the last 15 years how much we want to have a baby? So I think this is something where public health nurses are really in a unique position to provide support to these families and say, you know what, it's okay to be frustrated and it's okay to have bad days. Being a parent is very, very hard. No matter how badly you wanted to be a parent, it's not going to be perfect every day. So, offering this education and that support can be really important. When you look at the statistics in Kentucky here of the children who die as a result of abuse, the top 3 indicators in the households are substance abuse, domestic violence, and criminal history. A very, very close fourth is either untreated or undiagnosed mental illness. I put that untreated and undiagnosed qualifier on there because that's important. There are lots and lots of folks, and probably many of you listening to this today, have some sort of diagnosed mental illness that is adequately treated and we're perfectly functional, good parents, functional members of society. It's the undiagnosed or untreated mental illness that raises the risk. Another thing that raises the risk, which I think probably all of us will not be surprised to hear, is having an unbiologically related male in the home with the kid. One study actually showed that those children are 8 times more likely to die as a result of maltreatment than children who weren't in the home with a non-biologically related male. Now, just to be clear, this study was talking about heterosexual couples, so this increased risk does not apply to same-sex male couples. We're talking about, usually a biological mom with her boyfriend, and it's the mom's boyfriend that's at highest risk. Now, when you look at perpetrators of physical abuse, the most common perpetrator is dad, biologically related dad. After that is mom's boyfriend. After that is mom. So even though the most common perpetrators are men, we should in no way automatically exclude moms or other women caregivers as potential perpetrators because they most certainly can be. And after the mother is a female babysitter. So men are at the top of the list, but women are definitely up there as well. One thing to be aware of, just as an aside, as far as statistics go, for those of you who have seen statistics about maltreatment as a whole that show that moms are the most common perpetrators, the thing to understand when you see this statistic is that when they talk about maltreatment as a whole, they're including neglect. And if you include neglect when you're counting these, who do we hold responsible for neglect in our society? Do we substantiate on dad or do we substantiate on mom? Mom. We always substantiate on mom. Dad can be anywhere doing anything, and rarely is the neglect going to be assigned to him. So you have to be careful when you're looking at statistics to make sure you understand what they're counting. When you look at children who are actually physically abused, it's father and mother's boyfriend that's the most common. All right, so now I'm going to test you to see how closely you've been listening. Hopefully this will be very, very easy for all of you. 4-month-old baby boy goes to the primary care site for his second set of shots, and everything's fine. Baby's growing well. Parents have no complaints. On the exam, we'll say the pediatrician sees 2 little fingertip-sized bruises on the back of each thigh. Ask the parents about them. The Parents say, you know, we don't know. He's a lot squirmier with his diaper changes than his sister ever was. We have noticed those here and there, but we never really thought much about him. Now, this is a nice family that the pediatrician has known for a couple of years. She's actually seen the older 2-year-old sibling for the last 2 years. She's never had any concerns about this family. They don't have any risk factors, at least that she's aware of, that would make her think about abuse. What does this doctor need to do? Speak up. Workup. Okay. How urgently does she need to do that workup? Now. Very good. So the doctor needs to do an emergent evaluation for physical abuse, and that can't be done in a doctor's office. That means the child needs to be sent to an emergency department where there is lab and radiology and a head CT available. But what if that doesn't happen? What if you, I know probably few, if any of you are nurses in doctor's offices, but let's just pretend you're in that situation. Or let's say that you're at the health department giving shots to this kid and you see the note from where they went and got their well checkup, or you're the one that sees the bruises yourself. What can you do in this situation if the doctor's not concerned? You folks out yonder can talk too.
We try to talk to the doctor, or you can make a referral to DCBS.
Very good. You can try to talk to the doctor. You can make a referral to DCBS. Both of those are appropriate. You can document what you're seeing. You can talk to the doctor again if the first time doesn't work. You can call forensics and have us talk to the doctor. Again, what you can't do is kidnap the baby and take them to the hospital yourselves. But here is something that's really important to understand, is that all of us are mandated reporters in the state of Kentucky. That means we are legally, not just ethically, but legally obligated to call CPS if we have a reasonable suspicion that abuse has occurred. Now that you know what you know that bruising on a baby is a very reasonable suspicion that abuse may have occurred. So it doesn't matter how not worried the doctor is or how not worried your colleagues are. If you are worried, you must call DCBS, okay? It's your responsibility. The way the mandated reporting law is written here in the state of Kentucky, it refers to any person who has reasonable suspicion. It doesn't say any doctor or any dentist or any teacher. It doesn't matter what we do or if we're employed or even if we're 18 or older. If we're a person and we're in Kentucky, we're mandated legally to report. Well, unfortunately, the pediatrician didn't understand the significance of bruising in this case. And this little guy was the very first victim of abusive head trauma that I took care of as a child abuse specialist. And he was brought into the hospital where I did my training via ambulance because he was having seizures at home. When he got to the ER, they did a CT scan and he had bilateral subdural hematomas. Once they got him stable enough to get a skeletal survey, he ended up having 13 broken bones, both old and new. He was 4 months old. And part of my job as a child abuse pediatrician is to get that child's past medical records from his pediatrician. And so it was after those got faxed to the hospital that I made the heartbreaking discovery that he had just been seen the week before. And when he was seen, he had bruises. And those bruises should have alerted the doc, who was incidentally a very good doctor, a very well-respected doctor in the community where I did my training. She just did not know what bruises in babies could mean. She had documented the bruises, documented the explanation. She put nice family, very appropriate, no concerns. Okay? And that's all she did. She didn't call CPS. She didn't do an additional workup. At the time that he had that 4-month checkup, his head circumference was still normal, right at the 50th percentile where it had always been. As you can probably tell from this picture, by the time he came into the ER a week later, his head circumference was completely off the page. It wasn't just above greater than 95th percentile. You couldn't plot it on the piece of paper because his subdurals were there, but more so because his brain was swollen. So what are the lessons that we learned from this little guy? Well, again, bruising in babies is not normal, and we cannot ignore it, and we must do something about it. The second thing, and this is really big, is that maltreatment can and does occur in quote-unquote nice families. So I just, spent a good chunk of time talking about the risk factors and the things that many of these families and kids have in common. But the truth is, we can't ever tell. These can be our neighbors, they can go to our church, these can be people we grew up with. Just because they seem nice does not mean maltreatment doesn't occur in that family. And that was part of the mistake that this pediatrician made. Because the parents seemed nice, they dressed well, they lived in a nice neighborhood, they actually went to a church that she used to attend. I mean, there were all these setups for her to have a bias in favor of these folks. And I'll tell you, this dad could have won an Oscar. When I told him about all the injuries that his child had, he boo-hooed, and you would have thought that he, hung the moon and loved this kid so much. Within 18 hours, he had confessed to all of it with police. So we can't tell. We can't tell by looking at people or listening to how they talk or how many tattoos they have or whether they come on a motorcycle, whatever our biases are. You can't tell. The absence of risk factors is not the same thing as the absence of risk. And there's actually research to back this up. When we look at kids who have had missed cases of abusive head trauma, it turns out that the ones that are coming back over and over and over again and not being identified are the ones who we tend to perceive as quote-unquote nice people. Because most medical providers are white, that's going to apply to most patients. So actually Caucasian infants are more likely to be missed. This is really sad, but child maltreatment and child abuse in general is one of the very few areas of medicine where African American children get better care. But it's for all the wrong reasons. Okay? It's because medical providers are more likely to be suspicious, more likely to send them for evaluation, more likely to call CPS. And while it's good that we're picking up on those cases early, it's obviously for all the wrong reasons that we're doing that. So we have to keep in mind that, we have to recognize our internal biases and make sure they don't affect our decision making in these cases. So getting to the prevention piece of this, what can you do? Well, first of all, you can recognize all the early signs and the presenting signs that I've talked about already. Again, don't be afraid to share what you've learned today with the other professionals you work with, including physicians. Document any signs or symptoms that you see. Document, in addition to intervening, document bruises. Let's say it's an older child and the bruises are maybe a little unusual, but maybe not quite to the degree that you feel like you need to intervene. At least write down that they were there and what the parents said the explanation was. Because if the child then comes in 3 or 4 more times with more bruises, we can look back and see that this has been happening a lot, and maybe the story will change. If the story changes, that can be a clue. But a changing history only works if the people who hear the initial history writes it down. Okay? So you have to write down the explanation that you hear. If you aren't in the position to take pictures of injuries, try to send the child to a place that can. I would encourage all of you to work within your organizations to see what kind of protocols can be set up to facilitate having photographs taken. Sometimes it'll be up to DCBS and police, but there are actually several medical facilities around the state that are realizing the benefits of photography, not just from an injury documentation standpoint, but for all kinds of other reasons. Sometimes there are weird appearing rashes and other things that we can take a picture and send to a specialist and get feedback without actually having to send the patient 2 hours away. So there are lots of good reasons to take pictures. Document information you receive from the parent or caregiver when you have suspicions. Whatever they tell you was the explanation for the injury, write that down. Or anything else that you're concerned about. If there's domestic violence in the home, you need to make sure you note that in the chart so that others can be aware of it. Document observations with the parent and caregiver and their concerns and reactions around the child. I'll give you an example. of this, and it's a disturbing one, so brace yourself for it. But this was several years ago, in the ER, a 2-year-old came in a full code. She was pulseless and non-breathing, and when she was in the trauma room being resuscitated, her mom and her boyfriend were making out in the corner of the trauma room. Now, obviously, that's inappropriate, to say the least. The chaplain intervened and kind of, redirected their energies, so to speak. But the really interesting thing about that was the doctor who was running the code was aware that this had happened, but she had kind of continued to focus on getting the child back, and they ultimately did, and the child went up to the ICU. The ER nurses, the ICU folks, pretty much everybody in the hospital knew that this had happened in the trauma room with the mom and her boyfriend, but not one person had written it down. So it was nowhere in the child's medical record until the doctor went upstairs to make sure that somebody had written it down, and then she wrote it down in the ER record that had occurred. So there can be things that are so significant and so important for investigators to know about that would give people a clue to how inappropriate some caregivers can be. But unless we write it down, it might as well have not happened, okay? I'm sure all of you guys know this, people will say and do things to nurses and in front of nurses that they would never dream of saying to or doing in front of doctors or police or CPS. And we see this all the time. The folks here in the room are nodding, but we see this in the ER where they're on their best behavior for the doctor when they come in. But when the nurses come in, it's like there's nobody there, and they'll keep talking on their cell phone, say, we got to get our story straight, actually saying that in front of the nurse. Well, if you hear stuff like that, write it down and tell the investigators, do something with that information. Don't just hear it and be disgusted and move on, okay? It's also our role from a prevention aspect to just be a support to these families. When we see those risk factors, when we get those teachable moments, let our families know that it's normal for babies to cry. No matter how good you are with babies or how much you love your baby or she loves you, she's still going to cry. And helping all parents understand that, whether they're new parents or not. It's how babies communicate. Sometimes there are lots of things we can do to try to soothe a crying baby. If we find that we're getting frustrated, and this is what we have to teach our families, if we find that we're getting frustrated, put the baby down in a safe place and walk away and take a break. Close the door, go someplace out of earshot. Don't leave town, but go somewhere to get a break. This is one of the few times that you'll hear a healthcare professional say, you know what, if you need to, go smoke a cigarette. Do whatever you need to do to calm down. And I think those are two of the most important prevention messages that we can provide to the families we interact with. Number one, that it is normal and fully expected for babies to cry. And number two, if we find ourselves getting frustrated with the crying, it's okay to put a baby down and let them cry. Crying is not going to hurt a baby. Being shaken will. Okay? There is a resource here in the state. The number is 1-800-CHILDREN. It's a toll-free number. It can be called from anywhere in the state, and they have trained volunteers that answer that line and can do crisis intervention. They can do resource linkage, any number of things to help support parents who may otherwise have no other place to call. Talk openly with everybody you know about the dangers of shaking. Okay, not just the families that you work with professionally, but the people in your personal lives too. Your friends and your family. I think that's one thing that's important for all of us to realize is that this information doesn't only apply to us in our professional lives. This is a real thing that happens to real people from all walks of life. So providing this education to everybody that we know can be important. Now, I'm not going to go through these in a lot of detail, but the next few slides are very specific things that we can teach to families, especially new parents and young parents, for how to soothe a crying baby. I think we oftentimes assume that folks know what to do when a baby cries, and many, many people don't, both mothers and fathers alike. So being really concrete about what kinds of things can be done can be helpful. You know, first of all, meet the baby's immediate needs. Make sure she's not hot or cold or hungry or sick. Call the doctor if there seems to be a fever or a cough or anything else like that going on. Pay attention to noise and the lighting in the environment. You know, if it's loud, try to take her someplace quiet. If it's quiet, try to take him someplace with a little more background noise. Oftentimes that'll help. Any kind of rhythmic movement, you know, walking with the baby, dancing with the baby, pushing the baby in the stroller, taking them for a drive in the car. We do not recommend putting the baby on top of the washing machine or dryer during the spin cycle, because then the shaking can knock the car seat off and then we have skull fractures and epidurals, and that's not good. So anything other than that is okay. You know, the vacuum, the white noise machine in the background, any of those things can help. Check to make sure the clothing isn't too tight. We've probably all heard about hair tourniquets and thread tourniquets. Little fingers and toes can get threads or even mom's hair wrapped around them and cut off the circulation. And those little sleepers and what am I trying to say? The little shirts that the babies can wear when they first come home from the hospital that have the mitts over the hands. Oftentimes, you know, moms will have the babies in that for a couple days and not bathe them or look at the fingers and toes. So reminding them that if the baby's crying and you can't calm them down, take a look at those fingers and toes. Again, though, if none of the soothing techniques you try work, put the baby down if you're feeling frustrated and take a break. There are things that we need to teach parents about soothing themselves. So if they've tried to do things for the baby and it's not working, they need to also remember to do things for themselves. Sleep when the baby sleeps. Don't expect too much of yourself if you're a new mom just home from the hospital. The laundry can wait, the dishes can wait. If the baby's sleeping, you need to sleep. All of the kind of typical advice we give new moms. We need to probably, well, there's no probably about it. We definitely need to work harder and develop new strategies for getting this information to the dads as well. Because oftentimes we're doing a lot of teaching with the moms, but we have to invite the dads into the conversation. And many of the dads or even moms' boyfriends are interested and do care and would like to learn. They just aren't coming to the doctor's appointments and we haven't figured out how to connect with them. Sometimes having scheduled respite, you know, knowing that you have a sitter coming either later that day or later that week is enough to get people through the tough times. So having regularly scheduled breaks can be important. Encouraging parents to talk to other parents about their frustrations and listening to music. Anything that can be soothing, like taking a walk, taking a bath, any kind of break to help take care of ourselves as parents as well. Now, there are a few different prevention models out there, and I'm just going to talk to you a little bit about them just to give you at least our perspective within our program on these models. One is called the Happiest Baby model, which you guys have probably heard of the books, The Happiest Baby on the Block and The Happiest Toddler on the Block. And this is a great book. Harvey Karp wrote these. He's a pediatrician. And the whole concept is this fourth trimester idea, where he gives a lot of really great techniques for helping to soothe a crying baby, okay? And they're wonderful. The thing that I think that comes up short in this book, and this is just my personal opinion, is that he sort of implies throughout the book that if your baby continues to cry after you try all this stuff, you must be doing something wrong. And that's, I think, not an altogether helpful message to send, because we all know that no matter what we do, sometimes the babies are just going to keep crying, okay? There's another prevention program called the Period of Purple Crying, and it talks a lot about the crying curve and how there are certain ages and stages where babies are going to cry no matter what you do. And so they really emphasize permission to parents to just put the crying baby down and walk away, which I think is really important, but it comes up kind of short on the soothing technique side. It doesn't give a lot of really concrete things you can do to try to help comfort the baby. So the one that we like the best, and again, just to confirm, I have no financial attachment to this at all. This is just my own opinion, is the Portrait of a Promise is the one that we like the most, and this is the one that the Norton Healthcare Systems are using up in Louisville, and the child advocacy group at Kosare Children's Hospital is trying to get this spread to all the birthing hospitals in the state. And that is called the Diaz model. And Mark Diaz is a neurosurgeon who developed this program when he was in New York. And actually, when they put this into place in their community, they reduced abusive head injury by 50% in their community, which is amazing. Just by teaching birth parents in the birth hospital about the dangers of shaking a baby, some very concrete soothing techniques that are very helpful, but also permission to put the baby down and walk away. And that's the one that we like the best, and consequently the one that's used at Kosare and that's advocated by their group and ours. So again, just to emphasize, the two main things in education that are important is that crying is normal in infancy, provide specific tools for soothing a baby, but if they don't work, put the baby in a safe place and walk away to take a break. All right, these last few slides are just going to summarize some key points, and then we'll hopefully have about 5 minutes to take questions at the end, if you'd like. First, abusive head trauma is the most dangerous and deadly form of child physical abuse. Experience tells us and research tells us that we often fail to recognize the early signs of this and therefore miss opportunities to intervene and prevent further harm to these kids. Nurses play a vital role in observation, documentation, and intervention into this phenomenon. The absence of risk factors is not the same as the absence of risk. Don't forget about the 10-4 bruising rule. Again, that's torso, ears, and neck in any child 4 years of age or younger, or any bruise anywhere in a child 4 months of age or younger. The thing that goes along with that is that those who don't cruise rarely bruise. A thorough medical evaluation is crucial, and not every medical facility or provider is equipped or trained to do it correctly. The long-term effects of abusive head trauma vary from subtle learning and behavioral issues to complete dependence for all care. Education of caregivers regarding techniques for soothing a baby and the dangers of shaking can be an effective prevention tool. Contrary to popular belief, abusive head trauma is not usually a one-time event. It's more often the culmination of an ongoing escalation of violence against the child. Non-offending caregivers are often not aware that this is happening. Now, I didn't mention this earlier, and I should have, but oftentimes the person who brings the child for care is not the person who hurt the baby. And so they're only telling you what they've been told. And they may very well be very nice and well bonded to the child and appropriate, but you don't know who else is caring for that baby. So that's yet another reason not to let our biases come in between ourselves and the evidence. So until we learn how to completely prevent this, recognition of the early warning signs is crucial. So again, just thanks to Kosare Children's Hospital that has the balloon there, State of Kentucky, Kosare Charities, and Prevent Child Abuse Kentucky. They all helped us come up with this together. And then I have some time for questions here.
You mentioned the boosters. Managing nurse force.
That's a good idea.
Good. Okay, so there was one question here about it's mandated for nurses but not physicians. What about social workers and CPS? Yes, social workers are mandated to receive this training. Frontline DCBS workers are recommended to get it, but DCBS is already putting it into place. So we've already developed it for social workers and DCBS. So yes, it's going to take a while for all of that to get done. For all of the required groups that needed to be finished by the end of 2013. So we have another couple years trying to get this out there, but yes, they're required. Also, daycare providers have to get it. Certain groups of foster parents have to get it. The recommended groups were, jail inmates need to get it. Recommended groups were high school students. I would even go so far as to say middle school students. And there are some other recommended groups.